All right, today we're going to do something a little different. We're stepping right into the hot seat of a high-stakes oral exam for a consultant surgeon. And the case? It's a classic surgical puzzle, the adrenal incidentaloma. Now, this isn't just a made-up scenario. It's pulled directly from a real-world board exam, so you're going to see exactly how a top-tier candidate is expected to think on their feet under some serious pressure.
So here's our game plan. We're going to follow the exact same logical path a surgeon would, starting with the patient walking in the door all the way to getting them prepped and ready for the operating room. Let's get into it.
Okay, so picture this. You're the candidate. You walk in, you sit down across from the examiners, and the first slide of the case pops up. It's a pretty common starting point, but it's specifically designed to test your fundamental approach to a real diagnostic mystery. And there you have it, an incidentalloma, which is just a fancy way of saying a mass they found completely by accident. This single sentence, that's everything you get to start with. Your job, as the candidate, is to take this tiny bit of information and build an entire diagnostic and management plan from the ground up. And yeah, the clock is ticking.
Okay, now we get into what is arguably the most critical part of the whole thing. You know, any good surgeon will tell you that the answer is almost always hidden in the patient's story. It's all about asking the right questions, way before you even think about ordering a fancy scan.
The examiner kicks things off with this really broad question, and this is a test of how you think. A weaker candidate might panic and just start listing off a bunch of tests they'd order, but a strong candidate, they start exactly where they should, with a systematic, detailed history.
And this is what that structured approach actually looks like. So if you're the candidate, you're not just rattling off random questions. You're casting a wide but very organized net. You're asking about things like palpitations or muscle weakness, probing for signs of cancer like unexplained weight loss, and you're definitely asking about family history. You're trying to answer three big questions here. First, is this thing pumping out hormones? Second, could this be cancer? And third, is this part of some bigger genetic picture?
And boom, the examiner gives you this crucial piece of the puzzle. This shows you just how powerful a good history is. Anxiety, a pounding heart, tremors. This combination of symptoms is a massive red flag for way too many catecholamines, the fight or flight hormones. Right away, your brain should be locking onto a very specific diagnosis.
The examiner keeps the pressure on. No time to waste. You've got a targeted history, so what's the next logical move? You've got to look for physical evidence to back up what you're already suspecting. The candidate has to lay out a focused physical exam.
So the physical exam isn't just a random checkup. It's a targeted hunt. You're looking for signs of cortisol excess, things like those purplish stretch marks called striae. But let's be real. Given the patient's symptoms of palpitations and tremors, the single most important thing you're going to check is the blood pressure. A patient with this kind of hormone excess is almost guaranteed to have high blood pressure. Okay, so you've got your clues from the history and the exam. Now what? Well, the examiners want to see your list of suspects, your differential diagnosis. This is where you really get to show them your depth of knowledge and that you can think logically.
And here's a pro tip for any exam. Categorize your differential like this. It proves you're not just throwing out names, you're thinking methodically. The candidate here correctly groups the possibilities into hormonally active, benign, and malignant. And let's be honest, based on those symptoms, pheochromocytoma is sitting right there at the very top of the list.
So we've got our lineup of suspects. Now it's time to bring in the lab and imaging to unmask the real bad guy. You, as the candidate, have to present a really clear step-by-step plan to get the definitive answer.
And the plan you lay out has to be logical, right? You start with the basics just to see where the patient's overall health is. Then you move to the super-specific hormone tests. And here is the absolute key. You have to get this biochemical proof before you order the big, expensive scan. You need to know what you're looking for before you go looking for it. Given our suspicion, the tests you absolutely have to order are plasma and urine metanephrines.
And there it is. That's the smoking gun. The examiner gives you the lab results, and they're not subtle at all. These levels are through the roof, confirming a massive overproduction of catecholamines. For an exam? I mean, this is it. The case is practically closed.
But wait, the examiner is not done with you yet. You have the biochemical proof, but now they're pushing you for the next step. It's time to actually see this tumor, confirm where it is, and check for any signs that it might be malignant or has spread.
The CT scan gives us the final pieces of the puzzle. It shows a single, pretty large mass on the left adrenal gland. And the size, 6 centimeters, that's a big deal, because bigger tumors have a higher risk. The way it looks on the scan is totally consistent with what we're suspecting. We now have the complete picture.
All right, this is it. The moment of truth in the viva. The examiner wants a clear, confident, definitive answer. All the evidence you've gathered, the history, the exam, the labs, the imaging, it all points to one thing.
And the candidate nails it with confidence. Pheochromocytoma. It's a tumor that grows in the adrenal gland and just pumps out insane amounts of catecholamines, causing the exact clinical picture we've just spent all this time putting together. A perfect synthesis of all the data.
But look, making the diagnosis, that's only half the battle. With a pheochromocytoma, how you prepare this patient for surgery is literally a matter of life and death, and you can bet it's one of the most important things an examiner is going to test you on.
Now this right here is an absolute classic, a huge exam pitfall. You must start with an alpha blocker first, for a couple of weeks, to get that blood pressure under control. If you jump the gun and give a beta blocker to control the heart rate before you've done that, you get this thing called unopposed alpha stimulation, and that can cause a catastrophic, life-threatening spike in blood pressure. Getting this order wrong is a major, major red flag.
So once the blood pressure is under control, the last piece of the puzzle is hydration. And this is not some minor detail. Being flooded with these hormones for so long causes the body's blood vessels to clamp down, which basically means the patient's tank is running low. So you have to get them well hydrated to prevent a massive crash in blood pressure after the tumor comes out.
And the final test. The examiner wants to see that you're thinking ahead. A safe surgeon isn't just focused on what they're doing right now. They're anticipating everything that could possibly go wrong inside that operating room.
And a good candidate would list the big ones. The most feared complication is an intraoperative crisis, where just touching the tumor can cause a huge hormone dump and make the blood pressure go completely haywire. On top of that, the adrenal gland lives in a pretty crowded neighborhood anatomically speaking. It's right next to major blood vessels, so significant bleeding is a real risk. And finally, you've got to be incredibly careful not to injure nearby organs like the pancreas or the spleen.
And just when you think you're done, the examiner throws one last question at you, testing your long-term thinking. A successful candidate knows the job isn't over when the patient leaves the OR. They'd explain that about 10% of these can be malignant, so the patient needs lifelong annual checks for recurrence. They'd also mention genetic testing, since many of these are tied to inherited syndromes. And with that comprehensive answer, the viva is over. The candidate has perfectly navigated the case from a random finding to a complete long-term care plan, and that is the true mark of a consultant surgeon.